operating groups that help do the work. You are obviously attending the data facing, but if you're interested in other aspects of research computing support, you can attend one of the other systems. Just have to join the People Network, and then you should get the emails to let you know about the other setups. Our working and interest groups have other activities that are going on, such as the capabilities model. So if you're looking to start, research computing at your own institution, you can refer to these other resources. But we really hope that if you're here today as a guest, that you consider joining. If you're here as a member, you consider maybe being more active. We are always looking for people to join our steering committee. We are very grateful to have 2 new members with us. Sean Cleveland and Venice Baird are 2 new members, and we will be providing updates on what kind of talks that will be coming up. If you have ideas, you can also send those to us, and we can look for someone to talk on that subject. Today we have with us, actually, I have to be honest, it's someone that I actually have an interest in having come to this, because I've been working with Rabab on a project. So I'm not an unbiased participant in today's talk, but I'm very excited to have Rabab Alaraji with us today, who is the senior epidemiologist at CARES. She's been working with CARES for over 3 years, and prior to that had completed her master's degree in public health from Emory University in Atlanta, Georgia, and specializes in infectious disease. And as the senior epidemiologist at CARES, she manages and supports a variety of research projects, including one that I'm participating in, using the CARES data. Is responsible for analyzing, cleaning, coding, and producing visualized output of the data using statistical programs such as SAS and JUMP. And she has contributed to and co-authored over 10 research publications to date. And in our project, quickly learned how to use ArcGIS. I was so impressed with your skills there. So Rabab, I'm going to turn it over to you and tell us about CARES data.
Thank you so much. Hello, everybody. Thanks for having me. I will go ahead and share my screen. Can you see my screen?
Yes, we can.
Okay, awesome. So as Amy mentioned, I'm the CARES epidemiologist. So my main role at CARES is kind of the research and the data, but I wanted to kind of go over an overview of the registry and what makes the registry what it is today and how it's successful. So we'll go over a few of the aspects. We'll start with the background, kind of go over what is CARES over high level, and then dive into the data collection aspect, and then discuss how the data can be used for research, and then our general outreach and how we relay the information to laypersons and people of interest. So background. In 2004, the Center for Disease Control and Prevention, the CDC, collaborated with Emory University to develop a registry that could help increase out-of-hospital cardiac arrest survival rates. The CARES mission is to help communities determine standardized outcome measures for out-of-hospital cardiac arrest, allowing for quality improvement efforts and benchmarking capability to improve patient care and increase survival. The CARES vision is to become the standard national out-of-hospital cardiac arrest registry within the next few years. So CARES helps participants determine pretty much the basics of cardiac arrest, the who, the where, and the when. CARES also helps participants compare survival with other communities and then use that information to determine how they can make improvements in care. Hospitals, EMS, ambulance, fire departments, as well as researchers all use CARES. So this graph represents the number of cases captured each year. CARES began collecting data in 2006 with almost 1,500 cases. And last year alone, in 2021, we collected a total of almost 150,000 cases. So you can see the jump in the past 15 years. The program has expanded since 2006 to include 30 state-based registries plus 50 community sites in 16 additional states, representing a catchment area of approximately 170 million people, or 51% of the US population. Everything highlighted in blue are the states that participate. From 2006 to 2021, the registry has captured a total of over 800,000 records, with more than 2,200 EMS agencies and over 2,500 hospitals participating nationwide. So next, we'll dive into the data collection element of the program. So CARES is a secure web-based data management system in which participating communities enter local data and generate their own reports. So communities compare their EMS system performance to de-identified aggregate statistics at the local, state, or national level and discover practices that could improve emergency and cardiac care. What makes CARES an efficient data collection solution for communities is the web-based software which automates the linkage of an EMS record with hospital or dispatch data when available. So basically, the software collects and links data sources to create a single de-identified record for each event. EMS entry initiates the event. And then once that information is in the system, there are numerous reports that can be accessed, as well as the data can be exported into Excel format. The software is designed with simplicity in mind, and CARES can support high-performing EMS agencies in any community, as well as those that may be collecting data for the very first time. So over here is the CARES form. I just wanted to kind of go over this with you. I know it might be a little bit of too much detail, but I thought it would be interesting to see the fields that we collect and how these can be used for research. So as you can see here, this is the trip sheet that end users fill out, and there are about 70 multiple choice questions. 50 of the questions are mandatory and must be filled out in order for the entry to be considered complete. And if those 50 are if any of the fields are missing, then the CARES software pretty much flags that record, and it's the EMS agency user or the hospital has to go back and complete the entry. So some of the mandatory data elements include the demographics, such as the sex or the race or ethnicity of the patient, as well as arrest-specific data. So we collect the location type of the arrest, such as whether it's a home or residence or public commercial building, street, highway. We also obviously collect the address information, like the incident address, but these are not included in the data set because we stripped that information. And then we also collect resuscitation data such as CPR initiation, whether AED was applied. And then some of the optional elements in the form are the time variables. So at the bottom here, you can see the time call received at the dispatch center, the time the ambulance was on the route. These are supplemental, and that's just if the end users have time to fill them out, they will, and if not, then they can just keep it with the most important fields that need to be filled out. So some of the hospital data elements that receiving hospitals need to fill out include the emergency department outcome, the discharge location. So for example, if the patient was discharged to a nursing home or a rehab center, or if they were discharged home and they had a good survival outcome. And then there's also the neurological outcome at discharge. So for example, if the patient was in a coma state or if they had a severe or moderate disability upon discharge. So some of this might be a little bit too scientific, but the point of it is to show you kind of some of the fields that some researchers might be interested in looking at. So for example, we've had some researchers interested in looking at how the race or ethnicity might impact CPR initiation, or how the sex might have an impact on survival. Sometimes I want to look at, for example, who's more likely to receive CPR. Is it somebody who had an arrest in a public or commercial building versus a street or highway, etc. So this is just to show you kind of the fields and how they can be used for research. The CARES quality assurance process is one of the strengths of the registry, because basically there are several measures that are taken to ensure the integrity and cleanliness of the data. So this includes standardized training of all CARES users. There's a built-in software logic, and then an automated audit algorithm ensuring data validation across the entire data set. So as mentioned previously, in order to provide consistent data validation across the registry, each CARES record is reviewed for completeness and accuracy through an audit algorithm. If any field is missing or incomplete, that record is flagged. So this is a breakdown of the way that how the training of the CARES users is done. So basically, we have the CARES Associate Director, and the Associate Director trains each state coordinator on the data collection and auditing process. And then the state coordinator trains their local EMS and hospital contacts on this process and oversees local data collection and audit feedback. So this, I'm not going to go into too much detail, but this just kind of sums it up and breaks it down on how the associate director trains the state coordinator, and then the state coordinator oversees each hospital and agency in their state. And then once the records are complete, once a record is complete and been audited and is considered complete, then the record is scrubbed of patient identifiers. All right, next we'll go into the research aspect, which is my favorite part, and the part that I work mostly on. So sometimes we will receive some requests from researchers, from someone who's interested in looking at the data for a research project. That could be from a doctor, it could be from a PhD student, it could be from a master's student looking to do their thesis, a research fellow. So they request the data, and what we ask them to do is basically fill out a data sharing proposal application. And it's an application that breaks down what their analysis plan is, how they plan on doing the study, details of the study, and each unique project requires a separate proposal. And that's also our way of keeping track of how the data is being used and ensuring that there's no duplicate studies being done. Once they fill out this data sharing proposal application, we share that application with a data sharing committee. So each data sharing committee, so we have a data sharing committee on the national level. So if a researcher is interested in looking at national level data, we have them submit the proposal, and that's shared with the data sharing committee. This is a group comprised of about 6 members. They'll review the proposal, and they'll provide their feedback on, for example, scientific merit and the contribution to the field of resuscitation science, because these are typically the committee members are people who typically know more about the scientific aspect and can weigh in on that. So they'll review the proposal and provide feedback and either approve or disapprove of the study. If the study is approved, then the researcher then must sign a non-disclosure agreement. Each study has a non-disclosure agreement. There's an NDA for each project. So the researcher would sign a non-disclosure agreement, basically signing off that the scope of the project is limited to what's in the proposal, and that the data can't be shared outside of the study group, and that the data will be discarded once the project is complete. After that, I'll schedule a dataset review webinar with the group and just go over the dataset and the supporting documents to kind of help ease the process of starting the project and knowing what resources they can use. And then the next steps are all reviewed by the data sharing committee. So if the researcher completes an abstract or a manuscript within a couple months, they'll have to submit that, and it's reviewed by the committee, and the committee then again provides feedback, approves or doesn't approve it, and then that's pretty much the cycle, and then they can submit it for publication once approved. So local EMS agencies and hospitals have complete ownership of their own data. So before sharing the data with researchers, we clean the data set to ensure that there's no identifying information. So we don't allow any researcher to have access to the patient identifying information. This information is anyway scrubbed by the state coordinators once the data set is finalized, once the data is complete and the records are entered. However, we remove all the incident address information. We remove any EMS agency information or destination hospital, because each agency owns their data. We wouldn't want to use their data in a non-approved way. So we strip the information. And if a researcher is interested in controlling for EMS agency, then we can apply a random ID. So instead of having the name of an EMS agency, they'll just have the EMS agency number 324, and then they can use that for their study. So once a year, usually in April, there's a week when the data set is finalized for the year, and all records are completed, and we basically hold the system so no new records can be entered, and we export the data, and then we culminate the data set, and then we send it to the CDC, and we have them geocode based on the address of the arrest. So they add the latitude and longitude of the location of the arrest, as well as the census tract information. So census tract number or the block groups, etc. We can then they send that back to us. We then use that information to link the data set to census tract variables such as the median household income on the census tract level, or the race or ethnicity on the census tract level. So basically that's like the neighborhood level. It's a little bit it's smaller than like a zip code or a county. So we add that information in case some researchers are interested in doing that. And then sometimes some researchers are interested in looking outside the scope of looking outside of what the data set provides. So for example, we've had some researchers interested in looking at, for example, a current research study is one researcher is interested in looking at how historical redlining of neighborhoods has impacted survival of out-of-hospital cardiac arrest. So what they did is they pretty much sent us the redlining information that they have, and that was on the census tract level. They send that to me, and then I'll link that with the CARES data set, and then strip any of the identifying information before sending it back to them. So I basically act as the honest broker. We don't ever share census tract information or any identifying information, location of the arrest or anything with any researcher. So it's sent to me. I'll do the linkage on my desktop, and then strip all the information. If they want to control for census tract, for the census tract area, then we can also put a random ID. So there's also different ways that the data set can be linked to other data sets. So I've just shared two examples of two recently published papers. So this first example is the Association of Ambient Air Pollution. So this researcher was interested in looking at how air pollution could impact cardiac arrest outcomes. So what he did was he had the air pollution data, and it was on the county level. So he wanted it to be linked on a county and by the day, because it's based on the pollution by day. They sent it to me, and then I did the linkage, stripped all the county level information, and then sent it back to them for the study. And then this other study is an example of how the data set can be used to link other data sets not on the geographic level. So this is a study by Paul Chan's group, and basically they were interested in looking at how they can link the CARES data set with the Medicare records. So they used the CARES data set between 2005 to 2010, and then they linked it to the Medicare data set, looking at some date of the arrest, location of the arrest, and it's location. By location, I mean whether it's in a public location or a home or a residence, and all the they used 5 different de-identified fields in the CARES data set and tried to link it with the Medicare data, and they had like a 60% match rate, and that's how they did this study. So this is just basically how the different ways that the data set can be linked to other projects, to other data sets. So as of now, so currently in 2021, we have 74 data sharing projects ongoing. 52 are national level data sharing projects, and then 22 are state level projects. We have 113 peer-reviewed publications to date. You can find the list on the CARES website by clicking this link below. Lastly, I'll just go over how CARES engages the public and the general outreach. So we have a couple of different forms and different ways of engaging the public. So every year we publish a report, the annual report, and it kind of sums up the data set for the year and provides descriptive figures and tables of the data. Feel free to, these are all hyperlinks, so feel free to click on these and look at how the data is presented. We also have a CARES video and a YouTube channel and a Twitter feed. And our goal is to always engage and educate professionals or key decision makers in the larger community about the registry and drive change through the measure and improve model, and basically help translate quality improvement to lives and save out of hospital cardiac arrest outcomes. So these are all hyperlinked, and feel free to click them away. And that's it. Thank you so much. Do you have any questions?
Actually, we have a couple of questions. So from the map that you showed at the very beginning, I was surprised to see that Georgia is not a participant, even though Emory University is in Georgia and this is the home of the data set. How does that decision to participate, is it done by a state body or is it by the individual hospitals or something else?
So that's based on the state level. So there would be key stakeholders who are interested in participating basically, and they'll have to provide funding they provide funding in order to onboard the state. I'm not involved too much in that process. That's more of the director's roles, but yeah, sometimes some states will onboard and then choose to leave for whatever reasons, and then they'll come back at some points. That's very uncommon, but that was the case with Georgia at one point.
I guess as a follow-up, is there like you said, you do some outreach, but is there an active desire to have all states participant and like energy put towards recruiting of all states, especially the ones that are not already participating?
Oh yeah, absolutely. Yeah. So the CARES associate directors are constantly kind of trying to get states to onboard, and it's more of a process. The state has to approve to join, and that's like that's our goal, is to get all the states to join.
There's a second question. Would you please explain the difference between CARES and Get With the Guidelines cardiac arrest data set from the AHA?
I don't know about this registry. I couldn't speak to that.
I don't know if
Yeah.
if
This
Eleanor,
is
if you want to.
Eleanor. Yep.
Okay.
So there's and it's the American Heart Association. So there's a data set that the American Heart Association uses that come from hospitals that, but I believe that's mainly inpatient cardiac arrest, but it's a way that they look to see what the rates of survival are by hospital or by region. So many of the national statistics actually come from the Get With the Guidelines, because those are the guidelines that are used to treat cardiac arrest. So I was wondering how this data set compares to that one.
Oh, interesting. I'm not too sure, but this registry is more for EMS agencies to use to kind of benchmark their performances with other local and national registry, other local and national agencies. So I don't know, I think it's more in terms of communities working together to kind of develop practices that make their agencies increase survival, essentially.
Okay, thank you. And actually, the next question was also mine. Okay. So because you said that 60% of your de-identified data in CARES could be re-identified using other data sets. So from a IRB kind of perspective, doesn't that raise questions? And like in epidemiology, you know that we usually shift data that you want to analyze, but you really need to de-identify because of these concerns. So how are you addressing that?
So typically whenever a researcher is interested in the CARES data, we work closely with the researcher to strip any identifying information. And in terms of the Paul Chan's project, like the project that I was just describing about Medicare, he wasn't able to re-identify the information, and the data set that he had from Medicare didn't have the identifiers either. He just got to de-identified data set and basically like through a machine learning model linked the two.
I see.
Yeah, he wasn't able to re-identify any of the information.
Got it. Okay.
Yeah,
Thank you.
no worries.
Is there anyone that would like to unmute and ask their question directly? I don't see any more in the chat or in the document. It looks like we don't have any more questions. Rabab, are you willing to share your slides with us?
Yep,
We can
absolutely.
put them in a drive and share them through the Google Doc. So
Sure.
that'll be available as well. So, okay, well, otherwise, really thank you. Oh, wait, there's one. It says, it sounds like as if some of the data prep work linking, removing identifiers is done on your local workstation. We often struggle on how to secure end users, often personal endpoints. Has the security posture of the endpoint been discussed?
Well, yeah, most of the de-identifying, etc. So actually, let me just backtrack. So when the data set, when an entry is inputted into the CARE system and the entry is considered complete, the system basically automatically scrubs patient identifying information. So we don't have access to the name or those specific patient identifiers. What we do on our local workstations, which is basically on the laptops or the PCs, is we just de-identify the agency names and the hospital names, but we don't have any of the patient identifiers in the data set. And typically, if ever we were to send the data set, for example, to a state coordinator or anything like that, the Excel sheet is usually password encrypted and sent to them. That's the best ways that we can ensure that the data is secure, but we don't have the patient identifying information. We don't even have the date of birth.
So Andy, does that address your question?
Yeah, more or less, I think. We constantly struggle at Duke with just the dividing line between what should be allowed with personal endpoints and what should be allowed with Duke provisioned and managed endpoints. And certainly encrypting documents is one step, but my concern would be also with what is happening on the endpoint when the documents are unencrypted, right? Which is why the security endpoints is often the sort of weak link in the process. And it certainly makes sense what you're saying in terms of the de-identification that happens automatically, and hopefully that's sufficient.
Yeah. Yeah, and the website is a secure platform, so that's our best way to go about it. So I see another question. The lat long information is the hospital address, what's used there. So the lat and long information is basically based on the address of the arrest. So if a cardiac arrest occurred in a shopping mall, then based on that incident address, the latitude and longitudes are applied. Does that answer your question? No problem.
And I do know that if the I mean, that kind of information is also a variable, like commercial location, private address, work address. That's one of the variables that's in the care, so that you could look at that as well, right?
Yeah.
But it doesn't necessarily mean if it's a personal address, if it's somebody visiting someone else,
Exactly.
it doesn't distinguish if they're the homeowner or the rentor or whatever, something like that. It's just that it occurred in that location. So.
Exactly.
Okay, are there any more questions, or if somebody wants to save time from typing, you can go ahead and unmute and ask your question directly.
I have a question about how it started. Was this like PI at a university got a grant to start a registry, or was it like a commercial funded, government funded directly?
Yeah, it started off as a grant and was funded by the CDC.
I'm curious about, I don't know if I missed this or not, but what is the turn down rate for requests? Like if people ask for data?
The turn down rate, like how many of them are rejected, you mean?
Yeah, yeah.
Not many, honestly. I mean, I would say we get 50 or 60 proposals every year, and 3 might be rejected, and it's typically just because there might be another study that's very similar that's already ongoing, so we would reject that project.
Okay. Are there any last minute questions? Otherwise, Rabab, I really appreciate you coming today and sharing about this data set and kind of the background and how you work with researchers. Given that the data is identifying, and this is complicated in a sense to sometimes get right when working with researchers, but the guidance that you provide to make sure that they don't make big mistakes by releasing that kind of information, or you're protecting the information is it's interesting to see that process. So thank you for sharing that with us.
Yeah, of course. Thanks for having me.
And as I mentioned, Rabab is going to send the slides and we'll link them to the call doc. And so everybody can see the call doc, and then the recording again will be available on the YouTube page. So check it out afterwards, and enjoy the rest of the day. Thank you very much.
Thank you.